And so now we're on to part 2 of chapter 14. This is part 2A. Let's proceed, shall we? And I have the, shall we call it the study guide? It's a bit brief, but it does cover the essential parts of this chapter. So make sure that you're being thorough when you're working through these bullet points. And here's the other one. Again, we've pretty much got to about here. So we are right about at this point. So part 2 is going to cover these last 3 or 4 points in chapter 14. We left off last time with this big mechanism, and yeah, there's a lot of steps here, but the easy way to learn this is to start with the skeletal muscle and then look where the differences are. Both cardiac and skeletal muscle involve, and smooth muscle to a degree, involve an action potential spreading across the surface. It's much less important in smooth muscle, but that has to do with the variety and the diversity of the smooth muscle and so forth. So I don't get there. In any case, we have an action potential here, and that can either arise because of a neural stimulation, like in the case of a sympathetic activation, or it could be because of adjacent calcium coming in, other possibilities. We got an action potential here. And we hit this voltage-sensitive L-type calcium channel, which triggers a positive feedback pathway. Calcium comes in, it causes the RYR to open. So the RYR is calcium gated. And so it lets calcium out, and you get this positive feedback where you get sparks that cause a large signal wave to pass through if you watch that video, which I hope you did. That calcium then triggers cross bridge and power stroke and that sort of myosin power stroke, cocking and flexing cycle. Now, one thing to note about that I mentioned this in the previous lecture is that maybe not all of the cross bridges are active. If you have a sort of moderate calcium signal, then maybe only a certain percentage of these cross bridges are active. Unlike skeletal muscle, where generally all the cross bridges that are available are going to be active if they are, in fact, you do have overlap of actin and myosin. But in the case of heart, you can have incomplete percentages. You can have 75 or 50%, and that will weaken the strength of contraction. So cardiac, that's an important difference, is that they can grade the number of cross bridges that are actively contracting. In any case, though, we do want to just basically keep it to a one cycle situation. Unlike skeletal muscle where you can hit tetanus and you can keep cycling, in the case of heart, we really only want to have just one contraction relaxation. Long refractory period, lots going on there. So we also have a very robust removal system for calcium, either primary active transport into the sarcoplasmic reticulum using ATP, or secondary active transport using this NCX. Very, very robust way of exporting calcium out of the cytosol, so you only have one contraction and relaxation per signal. Again, here's a really, really good YouTube video. Take some time. Time is your friend right now, so let's use it to become the very best you can be. As tough as it is right now and as stir crazy as you might be feeling, good time to really lock down some of the stuff that you wouldn't have had an opportunity to lock down otherwise. We also had those autorhythmic action potentials. Sodium here, calcium here, potassium here. This is called the funny current. And don't worry about the calcium right here. We're really worried about the sodium. Yeah, there's a little bit going on there, and that may be hormonally influenced and some other things, but it's primarily sodium leak that exceeds sodium export. You hear that again? It's sodium leak exceeding sodium export. So the more leak we have, the steeper it will be and faster the heart rate. The slower the leak, the shallower that curve will be and the slower the heart rate. And those I sub F channels can open and close differentially in response to hormones. So if you get a big dose of epinephrine, that curve is going to steepen. Okay, it's going to steepen and lead to faster heart rates. It's also going to affect calcium, stronger heart contractions. Now let's start taking this to the macro level. We have the autorhythmic cells, and there are those funny current action potentials, and we have the myocardial contractile cells with their action potentials. Let's start putting this together in terms of sort of the macro events. What I'm going to do is start moving towards the electrocardiogram and its role in cardiac physiology. In order to achieve unified contraction in the heart, whether we're talking about in the atria, squeezing the final 10 to 15% of volume into those ventricles, or we're talking about the ejection fraction out of the ventricles into the outflowing arteries, we need not only a unified contraction system at the cellular level, we need an electrical conducting system at the tissue and organ level. And so we have this set of systems that involves bundles of these autorhythmic cells called nodes. We have what is called the sinoatrial node. It's found in the right atrium, right next to what used to be called the vena sinus. Now it's called the vena cava. We have an atrioventricular node, an AV node, and we have internodal pathways. We also have these bundles and Purkinje fibers. So let's just walk through the steps here real quick. The story begins in the sinoatrial node. This is the basis for a normal heartbeat. If you ever hear the phrase sinus rhythm, what they mean is that the rhythm is being dictated in terms of rate by the sinoatrial node. So a sinus rhythm, especially if you have a normal sinus rhythm, that means the sinoatrial node is serving as the overall pacemaker. And the reason it serves as the overall pacemaker is that it has the fastest rate. There is a fail-safe system that I will be telling you about a little bit later that allows for the heart to continue beating in the event that we start to lose some of this electrical conduction apparatus. And so the sinoatrial node depolarizes just using that I sub F, those funny current. It depolarizes, transfers some action potential to the neighboring myocardial cells, as well as down these internodal pathways. So we're going to send a fast signal through the internodal pathways to the AV node, and a slower wave of depolarization is going to move through the atria itself. And so we have that fast internodal pathway signal going to the AV node, and we have a slow depolarization wave going through the atrial myocardium. And so we have that slow depolarization moving across the atrial myocardium. And don't forget, there's going to be a latent period there. There's a difference between the action potential and the onset of contraction. There's a latent period. So you're going to see a depolarization wave followed by a contraction from base toward the apex, squeezing blood down into the final 10 or 15% down into the ventricles. Now the AV node receives a signal pretty quick from the SA node, but the AV node is a little bit of a slow poker. It doesn't fire off right away. Even though it receives a message very, very quick, there's a built-in delay there. And I'd love to learn the mechanisms about that delay. That's really, really interesting to me. How is it that they can receive a signal and then kind of sit there for a tenth of a second or so while the atria is contracting? So it's a built-in delay to allow atrial systole to occur. Once that delay is over, and it's about a tenth of a second, 15/100ths of a second or so, you send the AV node, then fires off big time and sends signal down what are called the bundle of His, okay, and the bundle branches to these things called Purkinje fibers, very, very much like a nerve. Those Purkinje fibers then depolarize the ventricle from the apex, the apical area, and trigger a contraction that should run from the apex towards the base, squeezing the blood out of the outgoing artery. So that depolarization wave moves up slowly, relatively speaking, from the apex of the heart this way, up along those Purkinje fibers, towards the base of the heart, squeezing the blood. So you have a depolarization, which you see on an electrocardiogram, and then you have systole, you have the contraction, which you don't normally see on an electrocardiogram. This is a great question. This question right here sets you up for some of the stuff that we're going to talk about in lab and so forth. So don't leave these figure questions behind. They're really, really good to help you better articulate the concepts. And that's all I want from you guys, is not only to get the concepts, but to be able to articulate them as well. In this slide, we've just stripped away the contractile apparatus, and all we have are the electrical conduction apparatus of the myocardium. Here's the sinoatrial node. Here's the atrioventricular or AV node. Here's the bundle of His, or they call it the His bundle. It's named after a guy named His. Here are the Purkinje fibers, again innervating the myocardium of the ventricles. We even have a bundle that goes over to the left side, the left atrium as well. It's fun to get to know these, because if you get to know these, then it's easier to understand some of what we see in terms of arrhythmias. But I'm not going to really test you on anything but SA node, internodal pathways, AV node, bundle of His, bundle branches, and Purkinje fibers. Those are the basic components. The sinoatrial node should be the general pacemaker of the heart. If you have a sinus rhythm, that means that the sinoatrial node is driving the rhythm. Folks that have what is called bradycardia, that is to say significant bradycardia, where their heart rate drops perhaps below, like for instance, let's say the SA node stops working correctly and the heart rate starts dropping below 50, they could run the risk of an arrhythmia, because that AV node, if left unstimulated, will be autorhythmic at 50. So if for some reason this SA node starts firing off too slowly, then this AV node will pick up at around 50, and there's a risk of arrhythmias if you start to get signals from here and here. That could lead to some issues. But there is that delay there. You get a fast signal through these internodal pathways, and then there's a delay here for about 1/10 of a second or so, 15/100ths of a second, and then it fires off the bundle of His, the bundle branches, and the Purkinjes, in order to allow for atrial systole, atrial contraction. Then we fire off that signal, goes up into the Purkinjes, and we get a wave of depolarization back towards the base, followed by a contraction, a ventricular systole. Let's say the SA node fails, or there's a break in the pathway and these guys no longer communicate. Let's say we have a severance of the communication between these two nodes. What you'll see is that the ventricles will start beating at around 50 beats per minute. You might even see flutter or contractions in the atria that have a different rate than what you see in the ventricles. The ventricles are beating at about 50. That means that it is driven by we call that a nodal rhythm, where it's an AV node that's driving it. And if we have a failure, say, at the bundle of His that separates these two nodes from the bundles and the Purkinje fibers, we might see an even slower heartbeat. This is that fail-safe mechanism I was telling you about. It's better to have a heart rate of 25 to 40 than it is to have a heart rate of 0. So if we have some sort of failure here, maybe there's an infarction or something, we have loss of conduction here, the ventricles will still fire off, albeit at a much slower pace. If they fired off at a faster pace, that would screw things up, because then you might have a conflict of signals. That's why it goes from fastest to next fastest to slowest, because otherwise it could cause problems. So sinus node, internodal pathways, AV node, we get a delay. After the delay, we fire off down the bundle of His, bundle branches, Purkinje fibers, and we get the ventricular side of the equation. And by the way, let's say we have an interruption of signal here, and what we're seeing is a rhythm that is being driven by the ventricle itself. We call that a ventricular rhythm. You ever hear of ventricular fibrillation or ventricular tachycardia, VTach? That means that the rhythm is the pace is being driven by the ventricles. We'll show you some of those things when we talk about arrhythmias. 60 to 70 in the sinus in the SA node, 50 or so in the AV node, 25 to 40 in the bundles and Purkinje fibers. The really cool thing about this electrical conduction phenomenon is that we can detect it externally on the surface of the body. And that phenomenon is, and the recording of it is known as an electrocardiogram, ECG, or if you happen to see the old German version of it, you'd see EKG. We can also do electromyographs, where we talk about muscular contraction, and we can detect electrical activity there. But we're doing this now specifically for the heart. And what it represents is all of the electrical activity at any given time of all the cells in the heart at that time as recorded on the surface of the body. So right here in time, or right here, or right here, here, and here. So it's a sum of all the electrical activity in the heart. And we do have to get into some basic physics for you to understand why the electrocardiogram is shaped the way that it is. That will also help you to understand why the waves will look differently from time to time. It's not enough just to be able to analyze a lead 2. We now routinely give patients 12 lead electrocardiograms. So understanding why the shapes are a little bit different is an important basic part of physiology and knowledge. So we're going to work on that a little bit. The technique of recording electrical activity in the heart was developed by a gentleman from Germany named Einthoven, and that's why it's called Einthoven's triangle, and that's why originally we called them EKGs as opposed to ECGs, because Einthoven was German. In any case, when he put electrodes in various locations of the body, on the arms or at the leg, and then set it up so that one electrode was positive and one was negative, he saw these waves show up. And so if he saw a wave between the two arms, he called that a wave, he called that orientation lead 1. But if he put one of the nodes down on the leg, he saw a different shaped wave, and he called that lead 2. And then if he went from the leg over here to the other arm, he called that lead 3. That's because when you're measuring electrical activity, the angle of reference, if you will, the frame of reference is important. And that's because the electrical activity not only has magnitude in the heart, but it also has direction. So if we were to look at, like for instance, let's say you're looking at somebody face to face. You're looking at them straight in the face. Their face looks like a certain shape and you see certain characteristics. And if you turn them 90 degrees so that they're looking to the side, their face may look very, very different. And that's true with electrocardiograms as well. The frame of reference, the orientation that which we set up the positive and negatives has influence on the shape. Electrical activity in the heart is what is known as a vector. A vector phenomenon not only has magnitude, but it also has direction. And so it's a vector phenomenon that we're dealing with when we're looking at different leads. In fact, 3 of the 12 leads, when I talked about the 12 lead ECGs, 12 lead ECGs, 3 of the 12 are 1, 2, and 3. The one you're probably most used to looking at is the lead 2. That's the one that runs the most parallel in terms of angle to the long axis of the heart, and it traditionally has been the most common of leads to look at. Again, as I mentioned in the previous slide, electrocardiograms are a vector phenomenon. So we define the positive and negative in the leads. And so if we have a deflection towards the positive, if the predominance of charge is moving towards the positive lead, that shows up as an upward deflection on the electrocardiogram. If we happen to have the predominance of electrical activity moving towards the negative lead, that registers as a downward slope on the electrocardiogram. And if it's even, if we have an equal number of charges going one way or another, there's no consensus into a single direction, that would result in a flat line on an electrocardiogram. Okay? So we can see this, whether it's oriented this way or that way, you would still be flat relative to the plotting on this chart. It's a vector phenomenon. It has magnitude and it has direction. If we change the angle at which we measure the electrical activity, we will change the shape of the rhythm that we record. Likewise, if we change the orientation of the heart or we change its electrical conductivity, that will also change the shape of the rhythm. And so this is in your book. So if you have upward deflection, that means more of the current flow is heading towards that positive node. You see an upward deflection. If more of the current flow is heading towards a negative lead, you would see it down. If it's equal in both directions, then it may be steady. Now, it doesn't mean there might not be a lot going on. It's just that the net electrical activity is not moving. In contrast to a vector phenomenon, we have what is called a scalar phenomenon. That is to say, on a scale. A scalar phenomenon is magnitude only. So to illustrate this, speed, the speed at which something moves, is a scalar phenomenon. However, velocity is a vector phenomenon. So for instance, if we have a car right here and it's trying to go to here, it's not going to go straight. It's going to drive all around these curvy mountainous roads in order to get there. It might be driving at 200 miles per hour, but if the net distance is only 100, so it might take an hour to get there going 200 miles per hour, but your velocity is only 100 miles per hour. Speed is scalar. Velocity is magnitude and direction. So in order to, as the car drives, you might have driven 200 miles, but as the crow flies, you've only gone 100 miles. So your speed may have been 200 miles per hour. Good luck surviving that. But your velocity would only be 100 miles per hour. So scalar versus vector. Scalar is magnitude only. Vector is direction and magnitude. And electrocardiograms are vectors. So if we change the orientation of the leads, we'll change the shape of the leads. If something changes in terms of the electrical activity and you have a given orientation, you'll see a change there as well. So those are the two possibilities for changing shape in an electrocardiogram. As I mentioned earlier, lead 2 is the most common lead for beginners. We typically look at lead 2 first. Lead 2 is actually ideal for looking at the atrial activity. It's actually really, really good for looking at P waves. QRS, Ts, those other ones, it's okay. It's not bad. You can get finer resolution in some of the other leads looking at, for instance, ventricular activity. But lead 2 is really, really good for P waves, really, really good for heart rate, that sort of thing. Okay? And that's our typical lead 2 rhythm. P, QRS waves, a QRS complex, and a T wave. Let's break out the electrocardiogram a little bit. First of all, the standard rate that an electrocardiogram tracing appears is 25 millimeters for every second. 25 millimeters is, if this is the 0 right here, 1, 2, 3, 4, 5 boxes. So if someone had a heart rate of 60 beats per minute, that's 1 per second. We'd have a QRS complex here, and we'd have a QRS complex here. You can see that this person doesn't have 5 boxes. 1, 2, 3, 4 major boxes between it, so it's actually faster than 60 beats per minute. But I'm going to come back to that later. But understand that the standard rate is 25 millimeters, and each one of these little light boxes is 1 millimeter. Each one of the heavy boxes is heavy lines is 5 millimeters. But let's get to the different parts here, shall we? Let's start with the P wave. By the way, I want you to notice something here. The P wave, the PR segment, QRS, and the T wave, none of those mention contraction. It is theoretically possible, and I have witnessed this as an EMT myself, to have an electrocardiogram but no contraction. So you do not suppose, even though you hear the beep on the electrocardiogram, if that patient is unconscious, might be a good idea just to check their pulse. In fact, they ram that into your brain in EMT and paramedic training. Always, 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 always check the pulse. Even when you don't have to check the pulse, check the pulse. Because they may have an electrocardiogram, but they may not have a pulse. No contraction here. No contraction. It's all electrical activity. So let's start with the P wave. P wave is atrial depolarization. Well, you might ask yourself, what about repolarization? Well, the repolarization is hiding because the ventricular rhythms dominate the electrocardiogram in that time that you would have atrial repolarization. If you had zero activity, if you had zero electrical activity in the ventricle, you just might see some atrial repolarization, but it's hidden in the wave because of the dominance of the ventricular myocardial mass. Then we have this thing called PR segment, which I'm showing you over here. That's different from a PR interval. The PR interval begins at the P wave and ends at the Q wave. And why they don't call it the PQ interval, I have no clue. Why don't they call it the PQ interval? I do not know. Same thing over here. The PR segment is at the end of the P wave and goes again to the Q wave. Why don't they call it the PQ? I don't know. Well, but we're just going to say it's a PR segment is the time between the end of the P wave and the start of the QRS complex. The PR interval is the beginning of the P wave to the QRS complex. So there's that PR segment, and that's that delay that I talked about in the AV node. This is where you're seeing that delay going on. The AV node's been stimulated, but it's not firing off. That QRS, Q down, R up, S down again here. This is the S, this little point, and this little point. By the way, don't freak out if you don't see the Q and the S waves. Sometimes you don't see those at all. What you want to see is this nice, thin, needle-shaped R wave. That is ventricular depolarization. Then we have the ST segment, which becomes really important diagnostically, especially when you're talking about myocardial infarction. You have that ST segment between the S and the T wave. That one actually makes sense. And then you have the T wave, which is ventricular repolarization. So this is ventricular depolarization, ventricular repolarization. Okay? Ventricular depolarization, ventricular repolarization. Atrial depolarization, ventricular depolarization, ventricular repolarization. Get those down first. PR segment, ST segment can come later. Start with P, the QRS complex, and T. Okay, get those down first, then you can start working on the PR segment and the ST segment. Here's a 12 lead for you. So we have Einthoven's triangle here between RA and LA and LL. That's the classic Einthoven's triangle. And then we start adding on other electrodes, and this is the result. By the way, here's our lead 2 rhythm, P, QRS, T, P, QRS, T. Looks a little bit funny there, doesn't it? Lead 2 down here, again, you see the little Roman numeral 2. The different shapes are due to the fact that we are looking at different frames of reference. You have 12 different frames of reference, 1, 2, and 3. AVR, AVL, AVF, V1, V2, V3, V4, 5, V6. So there's a whole bunch of these different things. And what you're doing is you are electrically dissecting the heart. It allows you to see with very, very high efficiency what's going on in different areas of the heart. As I mentioned, lead 2 is really, really good for P waves. Lead 3 is really, really good for ventricular activity. Lead 1 may be atrial activity. There's a little bit of ventricular activity as well. The different leads show different things, and it takes a lot of experience to really get to digest all these other leads. And that's why we're going to stick with lead 2 for the time being. So there's lead 2 right there. I forgot I had an animation there. Last slide of the talk today. Again, get these pieces down. You should be able to identify these on a matching question. P wave, atrial depolarization, QRS complex, 3 waves, a Q wave, an R wave, and an S wave. Turns out Q and S, and I want you to get this clear, Q and S waves are among the least important waves in all of the electrocardiogram. I don't know why, but students tend to fix on the Q and the S for some reason. Sometimes you don't even see them at all. Okay. We have PR segment, that's between the end of the P wave and the Q. We have PR interval at the beginning of the P wave and the Q. And then we have ST segment, and I'm not worried too much about QT interval all that much. Cardiologists would be worried about that. ST segment becomes really, really important diagnostically when somebody is having a heart attack. It will indicate the level of severity and the prognosis in the patient. But that's it for today. So get this down, get the electrical conduction stuff down, understand the difference between vector and scalar, and we will pick up with this in part 2B next time. Thank you for your time. Any feedback is appreciated, and I'll hopefully talk to you soon. Thanks.